I would like to invite our first speaker, Dr. Jayasudha. She will tell on role of transdermal patch in pain medicine.
So the topic is on transdermal patch that it's not working. Patch is basically a medicated adhesive. It's like a sticker which contains the medications. So through which from the sticker the medications go through various layers of the skin and it reaches the blood circulation and then reaches the systemic circulation. So the first FDA approved patch was for motion sickness, Copalamin, 1979. So mechanism is the drug is absorbed through the skin, avoids the first pass metabolism, and there is a controlled release of the drug. There is a mechanism in the patch which allows the drug to go at a particular rate. So there is always a constant plasma level that is maintained, and the components of the patch are the backing layer, the drug reservoir. I'll show the picture. So the mechanism by which it acts is by passive diffusion. Basically, there's a higher concentration of the drug in the patch, which creates a concentration gradient, and it goes from higher concentration to lower concentration as like in passive diffusion. So it depends on physical chemical properties of the drug, the skin properties, and stratum corneum, which is actually the rate limiting membrane in drug penetration. So if you see the skin, so we all know that the skin has epidermis, dermis and the hypodermis. So epidermis has an outer non-viable layer called the stratum corneum, that is here. This is a horny layer and it is the most difficult layer to penetrate. So this is the rate limiting layer which consists of corneocytes, which are protein blocks, and it is bound together by lipid matter. Actually it's something like brick and cement model. So then once it reaches through this and gets into the dermis, then it reaches the capillary circulation. So this is what is the rate limiting step. So skin being the largest organ has 2 square centimeters and it receives about 1/3 of the blood circulation. So the most of the blood supply is actually in the dermis level. So it serves as a barrier against physical, chemical and microbiological attacks. It has an important role in thermal regulation, in BP regulation, protects against UV rays, and diffusional resistance of the skin depends on the anatomy and the ultrastructure. So the non-viable layer, as I said, was a stratum corneum. It has the corneocytes connected with desmosomes, which are protein-rich appendages. Beneath that is the viable epidermis, which has 4 layers, that is stratum lucidum, granulosum, spinosum and the basal. The rate limiting is the stratum corneum. So these are the various pathways through which, if you see this picture, so this is the cells, the corneal cells. So drug can either pass through the cell, that is called the transcellular pathway, or they can go in between the cells, that's called the intercellular pathway. So there are 2 pathways. One is epidermis or transappendageal. In the transepidermal, we have the transcellular pathway. So the molecule, if it is more water soluble, will take this pathway. If it is more fat soluble, will take the lipid pathway. So the dermis is below the epidermis, and the most important point to take from here, it is rich in nerve and blood supply in this layer. Once the drug reaches this layer, it will reach the capillary circulation. Hypodermis is the underneath the dermis, which consists mostly of the fat and gives sort of a support structure to the organs. So routes of administration of the drug, we know that oral is there, intravenous is there, and transdermal is there. Oral, it avoids pain, it's easy to swallow. They say high patient compliance, but actually not. Patients can forget to take medications at proper time, especially, when pain medications are there, they may not be very compliant. And enzymatic digestion, mainly the first pass metabolism, GI side effects are more with oral medications. Intravenous, obviously, it's invasive. So even in children, it's not a very easy route to use. Even elderly with bad IV access, it's difficult. So transdermal, that way it's very less invasive, easy application, and avoids first pass. And the only side effect with this is you can have local irritation, and not many drugs are available in this form. So percutaneous absorption through the stratum corneum. So first step of absorption is dissolution. So the drug has to first come out of that polymer matrix onto stratum corneum. Then from stratum corneum, it takes either the transcellular pathway or the lipid pathway or the intercellular pathway. So this is the transepidermal route. So molecules which are more hydrophilic or more polar molecules will take the transcellular pathway. The other molecule which is more lipid soluble will take the intercellular route. And there is something called the shunt pathway, which is very in small amount of drugs go through this, because it goes through the hair follicle, sebaceous glands and the sweat glands. So the surface area of this is very limited. So the number of molecules that go through this is very limited, but this is very important for drugs which are very ionic or have larger polar molecules or high molecular weight. They go through this pathway. This is the steps that I have already mentioned, so I am just skipping through. So this is a simple equation. This is basically to tell that, so dq by dt is the rate of permeation, the rate at which the drug goes inside. So this is a permeation constant. CD is the drug constant in the donor compartment, that is a patch, and R is in the receptor compartment, that is in the body. So at all times the CD has to be maintained higher. That's when the passive diffusion happens. And the more the thickness, the less the penetration. The less the thickness of the skin, there will be more penetration. And partition coefficient is very important. The ideal partition coefficient is 1 to 4. The drug should not be too hydrophilic, the drug should not be too lipophilic as well. So it should be ideal, otherwise it will either hold on to the patch itself and it will not come, or it will hold on to the drug, lipid areas and it will not reach the systemic circulation. So it should have ideal partition coefficient, and apparent diffusivity. This diffusivity is the rate at which it can traverse through all the layers of the skin. So there are some factors that affect the transdermal permeation. One is biological, the skin condition of the patient, and the more hydrated the skin, the better the penetration. So many patches add humectant in it or something to humidify the skin so that the drug goes faster. There are some solvents like methanol and chloroform that can be added to increase the skin humidification. Age, the young one's skin is better than the elderly age group. Blood supply, again, if there is peripheral vasoconstriction, that affects the drug permeation. Region, they say behind the skin of the ear is more thin, and if we attach, the scopolamine patches are put there and nitroglycerin patches are put over the chest. So the regional skin site, the thicker the skin, the lesser the penetration. And skin metabolizes the steroids, hormones and chemical carcinoids. So certain drugs are metabolized in the skin itself. So we need to take that into consideration when using these, making these drugs. Then physiochemical practice, as I said, the hydration, if it is more hydrated, it better permeates. Increase in the skin temperature. So if a patient is febrile or the environment is more warm, again the penetration is more. As I said, the diffusion coefficient should be ideal between 1 to 4 so that the drug permeates faster. The molecular size of the drug is very important. You shouldn't have it more than 1000 Daltons. Anything less than 500 is more easier, and the drug dose also should not be more than 10 milligram. Then only it is ideal to make it as a transdermal patch. Similarly, you cannot apply it on a bruised skin or traumatized skin. That affects the transmission. Cold season, there is decreased penetration, and air pollution. If the dust clogs the pore, it increases the bacteria on the skin and decreases the penetration. Heat increases the absorption. So physicochemical properties, as I said, molecular weight should be less than 1000 Daltons, and the drug should have affinity to both lipophilic and hydrophilic at the ideal rate, and it should have a low melting point, and it should have a short half-life. And should not be irritant, it should not activate the immune system, and it should not be extensively metabolized in the skin as in steroids and other hormones that we took. So this is the parts of the patch. This is the backing layer, that is the outermost that we see. And this is the drug layer, the membrane, that is the rate control membrane. Then the sticky layer, the adhesive, and the adhesive covered by a thin liner. So these are the 4 layers. In the patches itself, there are different types of patches. You have a single layer drug, that is the adhesive itself has the drug in pockets. This is single layer. This is multi-layer, where there is an in-between rate limiting membrane. Just give me a few seconds. This is drug in reservoir, where there is a separate reservoir and then there is a rate limiting membrane. This is in the adhesive layer itself, there is a matrix. So this is drug in matrix. So different patches are of different formulations. And polymers are the backbone of the transdermal system. They should be stable, non-toxic and inexpensive, and their byproducts should be non-toxic as well. There is something called as penetration enhancers. That is, these products, if they are included in the patch, it will increase the permeation of the drug into the skin. I am not going into the details of this. The chloroform, methanol, acetone and these are all the permeation enhancers that are used. And there is something called as pressure sensitive adhesive, that is basically a specialized adhesive system where it sticks to the skin properly, because contact with the skin is very important for the drug permeation. Common uses, since it is for pain, fentanyl, buprenorphine, lidocaine and capsaicin are available for pain. Hormone, the other estrogen and progesterone patches, Alzheimer's, rivastigmine and other drugs. Since we concentrate with pain, we'll just stick to the patches used for pain. So buprenorphine is available in 5, 10, 15, 20 microgram. The patch is left for a week, and similarly patches need to be applied on a hair-free area, should be cleaned thoroughly with normal water, dried and applied without any wrinkle, and make sure the patch is stuck. So we usually put a tegaderm over the patch so that it stays in place and water doesn't permeate. Fentanyl 25, 50, 75 microgram per hour, it's changed once in 3 days. And diclofenac is available in 75, 100, 200 milligram per hour patch, that is for 24 hours. Lidocaine is available for neuropathic pain. This is available as a 5% patch. We can apply to a maximum of 3 patch. And the patch time should be for 12 hours. And after 12 hours, the patch should be removed, and there should be a patch free time of 12 hours before we reapply the patch. And capsaicin is available in both low dose and high dose. High dose is a single dose patch, 8%, where you leave it in the pain area, that is post-herpetic neuralgia. You just leave it in the area for 60 minutes, and then it locally depletes the TRP1 receptors and depletes the substance P. Or low dose patches can be used, that is used every 8th hourly. So these are the various patches. So advantages and disadvantages, we mostly know most of the advantages as I mentioned earlier. So there are new future prospects, that is microneedle patches which come with small needles that permeate into the stratum corneum. So this negates that barrier. So it is in such a way designed that it will directly go to the dermis, and the needle size and the length will be just enough that it doesn't damage the nerves within the dermis. And there are some smart patches with sensors. This is for insulin, which will detect the blood sugar levels, and then it will administer the needed dose of insulin. So these are all there in future prospects. And improved permeability technologies and personalized drug delivery technologies. So the effective drug delivery system improves patient compliance and safety, and there are a lot of scope to research and further advancements. Thank you for this opportunity.